First of all, we'll go through the mechanism of action because it is a little bit different from the well-known or established SGLT2 inhibitors, and then the role in acute heart failure and the role in chronic heart failure and patient at risk. Patients with heart failure are stuck in a cycle of hospitalization, readmission, and discharge. 8 out of 10 of patients with heart failure are hospitalized within a few years of diagnosis. 2 out of 3 will be readmitted once again. And over 40% of hospitalized will be readmitted more than 4 times. We know that the first 30 days after discharge are critical window to break the cycle of hospitalization for acute heart failure. 25% of patients are rehospitalized within 30 days, so you have to solve such a problem. And 60% of patients will be rehospitalized within 1 year. And we know the mortality is 50% in 5 years. International guidelines and expert consensus, 2024 ACC expert consensus, settled the pathway that ARNI of the 4 pillars of treating acute and chronic heart failure. ARNI is important. Evidence-based beta blocker like carvedilol, metoprolol, or bisoprolol. Mineralocorticoids, of course, you select the initial dose of mineralocorticoids, putting in mind the potassium level. And SGLT2, you can select dapagliflozin, empagliflozin, or sotagliflozin. Sotagliflozin is indicated in patients with heart failure to reduce cardiovascular death, hospitalization for heart failure, and urgent visits for heart failure. So what about the special mechanism of action? Addressing the unmet needs of cardiovascular risk management with SGLT2 inhibitors. The established rule of SGLT2 is to proven efficacy in preventing and treating heart failure, HFrEF and HFpEF, irrespective of the ejection fraction, irrespective of diabetic status, whether diabetic or not, and patients also at risk of cardiovascular risk or heart failure. It is limited by anti-atherosclerotic or antithrombotic effect. There is no data about reduction in the rate of stroke or MI. The SGLT2-1 inhibitors, which we are introducing today, they reduce the risk of stroke and MI, increasing some of the mechanism postulated, increasing GLP-1 and decrease in platelet activity and increase atherosclerotic plaque stability. SGLT1 inhibitors appear to add to the benefit of SGLT2 inhibition. Dual SGLT1 and 2 may offer added benefits over current therapies in patients with type 2 diabetes. And the role of SGLT1 inhibition added to SGLT2 inhibition needs further prospective studies. Characteristically, SGLT1 is present in the brain, the heart, small intestine, and kidney. It has a low capacity and high affinity for glucose co-transporter and responsible for 3% of urinary glucose reabsorption. The SGLT2 is proximal and convoluted tubules, and it has a high capacity, low affinity for glucose co-transporter and responsible for 97% of urinary glucose reabsorption. So both their expression and function are central to glucose metabolism. Dual SGLT2 1 and 2 inhibition, what is their core mechanism of action? The SGLT2 is usually located in the kidneys, and it determines significant excretion of glucose in the urine, similar to other selective SGLT2. This is known, but the added value is the inhibition of intestinal SGLT1, delaying glucose absorption and therefore reducing postprandial glucose. Why is inhibition of SGLT1 and 2 is important? The expression of SGLT1 and 2 is elevated in diabetes and cardiovascular disease. So the SGLT1 is elevated in left ventricle in heart failure, dilated myopathy, ischemic heart disease, type 2 diabetes, diabetic cardiomyopathy, and also in small intestine with diabetes. The SGLT2 is elevated in diabetic nephropathy and heart failure. So targeting hyperglycemia by inhibiting intestinal and renal glucose reabsorption by SGLT1 and 2 inhibitors is an appealing therapeutic strategy in type 2 diabetes with added cardiovascular and renal benefits. SGLT1 inhibition effects on the cardiovascular, renal, and metabolic function. SGLT1 inhibition reduces renal intestinal glucose absorption alters intestinal pH and microbiomes, increase the GLP-1 activity, and improves plaque stability, ultimately contributing to reduce heart failure events, stroke, MI, weight loss, and glycemic control. SGLT1 inhibition provides heart, kidney, and metabolic benefits beyond glucose control. The SGLT2 inhibition's effect on cardiovascular, renal, and metabolic function, it inhibits its beneficial effects through multiple mechanisms in the kidney, myocardium, and altered metabolism. It reduces renal glucose absorption, promotes osmotic diuresis and natriuresis, lowering intraglomerular pressure, and enhances myocardial efficiency, ultimately contributing to reduced congestion, fewer heart failure events, and lower risk of myocardial ischemia. The selectivity entails the function. So the most selective is the empagliflozin, but it is related to no effect on stroke prevention. But sotagliflozin has the same affinity for glucose, and also it has more effect on prevention of stroke. So what's the role of sotagliflozin in acute heart failure? We have the SOLIUS trial, which was made in acute heart failure. It contained adult patients with type 2 diabetes hospitalized for symptomatic worsening heart failure regardless of the LV ejection fraction. And the scored trial included adults with type 2 diabetes, CKD, and risk of cardiovascular disease, with or without history of heart failure, regardless of the ejection fraction. The common primary endpoint was the total number of composite cardiovascular death, heart failure, hospitalization, and visits for heart failure. So what about the SOLIUS trial? Patients with worsening heart failure required hospitalization are at heightened risk of urgent heart failure visits, recurrent heart failure hospitalization, and death. The focus of the early phase management in these patients is to relieve congestion with intravenous loop diuretics, stabilization of hemodynamics, and then optimization of the tissue perfusion. Once the patient is clinically stable and successfully transitions from IV to oral therapy, the pre-discharge phase focuses on optimizing the evidence-based treatment. That's the so-called 4 pillars. The ASR, and top of them is the ARNI, the beta blockers, and the mineralocorticoid antagonists. Serum glucose transporters, 2 inhibitors originally described as therapies for hyperglycemia, have now emerged as a powerful tool to reduce heart failure outcome in patients with heart failure with reduced ejection fraction. The study is designed as double-blind, randomized, placebo-controlled trial. Patients are randomized to 1:1, sotagliflozin 200 milligram as a treatment arm on top of standard of therapy and placebo, and in a couple of weeks you could upgrade the sotagliflozin to 400. And patients were followed up to 1 year and a half. Inclusion criteria: hospitalization, admission with signs and symptoms of heart failure, type 2 diabetes, received treatment with IV diuretics, stabilized off oxygen, transition to oral diuretics, and BNP more than 150 and more than 450 if AFib, NT-proBNP more than 600 and more than 1800 if AFib. Exclusion is the end-stage heart failure, recent ACS, stroke, PCR, or CABG in intervention in the coronaries, or eGFR less than 30. The baseline characteristics between the placebo and treatment arm were comparable in all aspects, whether you talk about the age, the sex, the race, the BMI, the A1C, the KCC score, the GFR, the diagnosis of diabetes, the ejection fraction, all were comparable. Also, the medication, where they were all comparable, you can also plot that minority were on the ARNI, like 15%, so you cannot claim ARNI improved these patients. Also, metformin was 90, almost 90%, not much. Okay, the primary endpoint was achieved by a relative risk reduction of 33%, and you need to treat only 4 patients for 1 year to prevent 1 event, so it's worth it. And it is statistically significant, decreasing cardiovascular death, hospitalization, or urgent visits for heart failure, with heart failure to the emergency. When you see the efficacy endpoint in selected pre-specified group, no difference between ejection fraction below or above 50. Geographic areas, no difference. Timing of the first dose, before discharge or after discharge. Sex difference, age below and above 65. GFR below or above 60. All sotagliflozin was better. So the benefits of sotagliflozin were consistent across pre-specified subgroups with a uniform treatment effect, observed across subgroups stratified by geographic region, ejection fraction, sex, age, renal function. All sotagliflozin was better. Secondary endpoints, it could decrease total number of hospitalization and urgent visits for heart failure by 36%. It could decrease total cardiovascular death, non-fatal MI, non-fatal stroke. Notice here, we are talking about a heart failure trial, but we are decreasing MIs and strokes, and also total number of cardiovascular deaths, hospitalization, urgent visits, heart failure events by 32%. So remember the 36 and remember the 28. This 28 is the added benefit of decreasing MIs and strokes. Also, the benefits were observed within 27 days. If you observe the curve starts to separate by 27 days. So by 27 days, you have less event in the treatment arm, and this is very soon. We are combating the early readmissions and the high mortality in the first 30 days of admission of acute heart failure. Also, a detailed analysis in the first 30 days, it could decrease the outcome of cardiovascular death, hospitalization of heart failure, or urgent visits of heart failure by 51%. And the first 90 days is 46%, and after 18 months, this is the final result of 33%. Adverse event, it was no difference than placebo. Maybe little increase in diarrhea, that's it, but no difference than placebo. So in conclusion, SOLIS trial demonstrated that among patients with diabetes worsening heart failure, the drug initiated before or shortly after hospital discharge significantly reduced cardiovascular death, hospitalization, and urgent visits for heart failure. It could show absolute reduction of 25.3%, means you need to treat 4 patients for 1 year to prevent 1 event. Only 4 patients, number needed to treat. Sotagliflozin, the dual SGLT 1 and 2 inhibitor, reduced urgent heart failure visits, cardiovascular death very shortly, within 27 days of initiation of the drug. In the post-hoc analysis of the SOLIS trial, it could decrease the relative risk and the outcome about 51% in first 30 days and 46% at 90 days. It led to improvement in symptoms, physical function, and quality of life within 4 months. Here we can see those trials used the same class early post-MI, the SOLIST, the impulse empagliflozin, and the DAPA-active, the dapagliflozin. And they followed up for 18 months, 3 months, and 2 months. We can see the outcome. Here you have a positive outcome within 27 days. If you see the impulse, you could have a positive trial, a significant p-value, but within the curve did not start to divergate unless after 60 days. And the DAPA-active trial was negative. What about the SCORE trial? It's heart failure, diabetes, chronic kidney disease are commonly occurring and interlinked, the so-called CKM syndrome, and they all potentiate each other. If you have a CKD with diabetes, you potentiate heart failure. If you have heart failure with diabetes, your risk of complications is 50% more. So this syndrome is evolving and being looked at recently. In this trial, over 10,000 patients were randomized to sotagliflozin versus placebo, and they were followed up for almost 2 years. You start by 200, and in a couple of weeks, you could upgrade the sotagliflozin up to 400 milligrams. Inclusion were patients aged 18 years or older, type 2 diabetes, A1C above 7, CKD, 1 additional major risk factor if the age is above 18, and 2 additional risk factors if the age is above 55. Exclusion when you plan SGLT2 inhibitor at the start, history of diabetic ketoacidosis, because they can develop euglycemic ketoacidosis, this class of drugs, unstable anti-hyperglycemics, or end-stage heart failure or history of dialysis within 1 year. In the demographic data of the patients, they were comparable, but here just I want to draw your attention that 30% of these patients were chronic heart failure. So we can rely on the sub-analysis here, and we have a look what it did for those chronic heart failure. Others were just at high risk. And these are the medication, and we can see ARNI was very limited in this number, just 1.2% of the patients. SCORE helps protect patients at risk of heart failure from a cycle of hospitalization. So it decreased the primary outcome of cardiovascular death, heart failure hospitalization, and urgent visits for heart failure by 26%. The number needed to treat was 54 patients for 1 year to prevent one event. Also, when we see the subgroup analysis by age, by heart failure status, by GFR, or by history of cardiovascular disease, or were in favor of using sotagliflozin, and we see those heart failure, they did well when they had it. The secondary endpoints, the total MACE of SCORE, composed of cardiovascular death, first and subsequent non-fatal MI, non-fatal stroke in patients with type 2 diabetes, CKD, and risk of cardiovascular, whether or not they have heart failure. The MACE was decreased by 23%, the total MI by 32%, and the total stroke by 34%. So always look to that secondary endpoint very nicely because it's not there. The other medication or the SGLT2 alone, you don't get these outcomes. Another meta-analysis quantified the contribution of pharmacological SGLT2 selectivity to clinical efficacy and safety outcome in patients with type 2. 6 placebo-controlled trials, the EMPIRIC, the CANVAS, the DECLARE, the CREDENCE, the VERTIS, and the SCORE. And they looked at the MACE, the fatal and non-fatal stroke, fatal and non-fatal MI, and hospitalization. And this meta-analysis included 57,000 patients. What we have seen in this meta-analysis that SG inhibitors with low SGLT2 selectivity reduce the risk of fatal and non-fatal stroke, especially those with low affinity for glucose, like when you go down to SOTA and DAPA and canagliflozin. What about the kidney effects? Composite kidney-specific and cardiorenal outcomes significantly reduce the risk by 38% of the composite of sustained more than 50% decline in eGFR or eGFR less than 15, need for dialysis or kidney transplant, 38% decrease in the event. In the sotagliflozin arm, it was 87 event, in the placebo was 136. Also, the eGFR, we have the same class effect when you have initial drop in the eGFR. You can see it in all SGLT2 inhibitors. You have initial drop in GFR. Within 4 weeks, that returns to baseline. About the safety data, adverse reaction were reported in around 2% of patients treated with sotagliflozin and greater a little bit than placebo. And the one you can just look at is the diarrhea, and it is soon resolving. Also, sotagliflozin is a once-daily oral treatment that can be initiated early in the hospital. The recommended starting dose is 200 orally once daily, not more than 1 hour before the first meal of the day, up-titrated in at least 2 weeks to 400. For patients with decompensated heart failure, dosing may begin as soon as the patient is hemodynamically stable, including during hospitalization or urgent outpatient treatment or immediately upon discharge. And of course, we are proud that it is the second country worldwide to approve the sotagliflozin after the States. It is approved in the UAE. Thank you, and I'll be happy to address your questions.